Good afternoon, everybody. First of all, thank you very much, Vijayawada Obstetric and Gynec Society, Dr. Suma, Dr. Jyoti for inviting me. Thank you very much. And it's really amazed to see all of you in so many large number. So, friends, I'm going to talk about clomiphene resistance. So, though it sounds like a very usual topic, but really one question before I start my presentation. Can you raise your hand if you are using 50% of your patient's clomiphene? How many of you really use it? Just raise your hand, please. So I do understand. And okay, so this is what those who uses clomiphene, this is what they suffer. The first cycle, they try to develop follicle, it doesn't develop. And second cycle, again, we increase the dose, it doesn't develop. Third cycle, again, it happens, and that brings a lot of frustration, and we just give it off. And we just want that patient somewhere to develop that follicle and give us some kind of hope that we can achieve a pregnancy. Now, friends, jokes apart, but strength doesn't come from what you can do. It doesn't come from what you can do. It comes from overcoming the things you once thought you could not. And that's what we are going to learn today. So, what are the principles of ovulation induction? It should come to our mind whenever we start the ovulation induction cycle. First is achieve a pregnancy in the shortest time. Now that instead of first intention, the last words are very important, and that is called shortest time. And that's what we have to really have aim. Then of course to avoid all those complications like multiple pregnancy and ovarian hyperstimulation. And we have these drugs as a ovulation induction agents. Nothing new for us, clomiphene, letrozole and gonadotropins. The concept of threshold for ovulation induction in PCOS is very clear that we want adequate stimulation. There is a threshold for stimulation. We don't want no response. Of course not, because that cancels our cycle. Which also don't want hyper response, so multiple follicular development, because not only we cancel because in view of ovarian hyperstimulation, but also increases the risk of multiple pregnancy. So what we want is a threshold for stimulation. Now what you mean by clomiphene resistance? So when you give a clomiphene, there is a failure of follicular growth or ovulation, very clearly. So there are two different terminologies, clomiphene resistance and clomiphene failure. The important difference is in clomiphene resistance, there is no follicular growth. And in clomiphene failure, where a patient has responded to your clomiphene, developed a follicle, she has ovulated, but she did not give a pregnancy. So that's completely two different. And we are going to deal with that clomiphene resistance. Now, this is more commonly seen in polycystic ovarian syndrome. There is a reason behind it. We are going to understand that endocrinology today. But these are the three things should come into your mind when you are dealing with clomiphene resistance in PCO patients. And that is presence of insulin resistance in that woman, hyperandrogenemia and the obesity. We know the basic endocrine defect is hyperestrogenemia, and that leads to hyperproduction of LH and reduction in the FSH. Now obesity, again there is excessive fat. It's going to contribute more estrogen. That's going to keep the FSH low and keep the LH low high. So these are the three things which has to come in to our mind, and that's why the whole management based on these parameters. Now let's understand and focus the diagram, because that is very important. If you look at the top part of the diagram, that is mimicking a natural cycle. So what happens on the first or the second day, FSH is normally in the range of 5 to 7. Now the moment there is a lower reduction in the estrogen level, the FSH rises. You can see the dotted line. Unfortunately, this pointer cannot work on LED, but the FSH levels goes beyond dotted line. That is, dotted line is a threshold for FSH. So to recruit the follicle, FSH has to go above this threshold level. Okay. Now once it goes, you can see, look at the down part of the diagram. There are 2 or 3 follicles which are recruited. Now the moment the follicles are recruited, they start growing, they are going to produce estrogen. Now once the estrogen comes into the circulation, it is endocrine principle is always the estrogen suppresses FSH. Remember that simple thing. Always estrogen going to reduce FSH. So that those FSH levels which have gone beyond threshold is going to fall down. The moment it goes again below the threshold, The couple of follicles, 2 or 3 follicles which are recruited, out of them only one will remain and 2 will go into atresia because there is a down in the FSH level, right? So if you understand similar, that's what is the dominant theory where a single follicle develop as a dominant follicle. Now we need to understand why clomiphene only has got these kind of effects and why in PCOS patient only this thing happens, not in unexplained infertility patient who are normal ovulating. So remember friends, the FSH level which is on the 5th and between 5 to 7 or 5 to 8 on second day, it is suppressed because of hyperestrogenemia. So it is more lower on the first or second day. So your anti-estrogenic drugs, they are not able to raise that FSH beyond the threshold, and that's why follicles are not getting selected. And that's why even sometimes we start with 50, then go to 100 and sometimes even go to 150, still it doesn't respond because FSH is not going beyond threshold, and that is typically clomiphene resistance. Now, what are the options we have? So we have metformin, we have aromatase inhibitors, gonadotropins, adjuvants, and ovarian drilling. 5 strategies. We'll understand each of them patiently. Insulin sensitizers. The first cause I said for clomiphene resistance is a insulin resistance. So obviously insulin sensitizers are going to help. We have many molecules now. Out of them we have to understand which is better. So this was way back in 2003 when metformin was compared with a placebo when initial studies, and it was clearly evident that ovulation rate was favoring metformin. If a patient is on metformin, she will spontaneously ovulate also if you compare with the placebo. So then 2003 onwards we understood the importance of metformin. Then came metformin combined with ovulation induction agents. So you can see these marked studies 2002, and these are the clomiphene resistant patient or PCO patients who were given metformin along with clomiphene, and they realized that it is giving us a positive odds ratio favoring the combination. The ovulation rates are increasing, which the same patient group was not responding to clomiphene. The moment you add metformin, they start responding because it reduces the insulin resistance. Then came 2012. This was a study which actually, there was some time where we started, let's not prescribe metformin because it said that it increases clinical pregnancy rate, but it doesn't increase the live birth rate, right? So 2012 onwards, again, there was a downfall for metformin because this study said that it doesn't increase the live birth. So the ultimate outcome is not increasing. So we didn't, feel like why should we give it? But you have to understand one statement that it increases the clinical pregnancy rate. Clinical pregnancy is a live pregnancy at 7 weeks. So our intention, we need to understand that there are several other factors, several other causes which can affect beyond 7 weeks, which can lead to miscarriage, which can lead to extreme premature deliveries or IUDs. So we cannot compare a drug for a live birth rate. That's very important. And that's what happens because of this study. It was for slight few years, we thought of that, no, let's not prescribe in every patient. But then we came many other studies like in this 2015, when they compared, that was a randomized systematic review of RCTs, they compared with gonadotropins, the combination of metformin and clomiphene, and they found that it resulted in significantly fewer ovulations and pregnancies. No significant difference were found when metformin clomiphene was compared with laparoscopic ovarian diathermy. So gonadotropins were better, but compared to ovarian drilling, metformin and clomiphene was much better. Then likewise, there was no difference were observed in comparison with aromatase inhibitors and clomiphene citrate. So what it told us that there are these 5 strategies. We need to understand what is our first choice, what is our second choice, what is our third choice. So aromatase inhibitors came in as a first choice, then came in as a clomiphene with metformin as a second choice, then third choice came in as a gonadotropins, and last choice came in as a ovarian drilling. So there is a evidence for the superiority of gonadotropins, but the metformin clomiphene combination is mainly relevant for clomiphene resistant polycystic ovarian syndrome patient. If not effective, the next step could be gonadotropins. So that was a conclusion of this review. Now, which insulin sensitizer is better? Can we have only metformin or can we give both? So this was only single study which was in 2019 done by our Indian faculty at AIIMS, and they concluded that if you give metformin along with myoinositol, there is a definitely significant increase in the live birth rate, as you can see 55% versus 26%. Now again, this study was little misinterpreted by many of us, because why should we talk about live birth rate? We don't want to test the drug by comparing live birth rate. But it did show that the secondary outcomes like improvement in menstrual cycle, hormonal and biochemical parameters, spontaneous conceptions, abortions were less, multiple pregnancies were less, ovarian hyperstimulation syndrome was less, and there is a significant improvement into menstrual cycle when you give both. So those secondary measures which were expecting that the drugs or agent should give us this outcome, they were much better in combination. So then came in a new protocol. We always love new protocols because it always criticizes the previous. The conventional protocol is that we give it from clomiphene from 2nd day till 6th day, 5 days of the early cycle. But can we do more? Can we reduce this resistance? So this is called a stair-step protocol. A stair-step is, as you can climb the stair, it is not only that you are continuing the drug, but you are increasing the doses. So that's what is stair-step protocol. So this was in 2015, 60 PCO patients who failed, who were clomiphene resistance, they were allocated randomly, where one group received conventional protocol, so 5 days clomiphene, that's it. And stair-step was, you give 50 milligram for 5 days, no response, continue with 100 milligram for another 5 days. That is called stair-step. And they found that ovulation and pregnancy rates were similar between the stair-step and the control group. Duration of treatment was significantly shorter in a stair-step. So somewhere if you continue giving clomiphene further from 50 to 100 milligram, probably you will still see a better result, shorter duration of treatment, and without affecting the ovulation pregnancy rate. So we are getting the similar pregnancy rate, we are getting lower cancellation of the cycles. So that was regarding some modification of clomiphene. Now let's understand the aromatase inhibitors. We know our favorite drug is letrozole, and we know that 2.5 milligram is the dose available, and let's understand how it is better. So when letrozole was compared with clomiphene, the biggest important difference we saw is that cycle cancellation due to ovarian hyperstimulation was 0% into letrozole group, and it was 5 to 6% almost in the clomiphene group. So very important complications of ovulation induction was 0 with letrozole, and that's why it is our favorite. Not only that, with letrozole, the endometrial thickness, the endometrial milieu was better, the pregnancy rate was much better, the rate of abortion was not so significantly different, and OHSS was significantly less. And that's why letrozole became our favorite drug. Now can we combine letrozole along with highly purified HMG low dose in clomiphene resistant cycle? How does it benefit? And when this prospective single and single central trial, the ongoing pregnancy rate was 28% per cycle. Have you understood? We always say 10 to 12% of pregnancy rate which we get normally in IUI cycles when we use oral ovulogens. With combination, we can actually go to 28% per cycle, and per patient, if you look at it, really goes till almost 68%. So that's something is a combination which is going to give us a better. The ovulation rate also increases almost 97%. We know with only letrozole we have 75-80% ovulation rate, but with combination it has gone further to 97%. So these few studies, so that was a comparison. Can we give letrozole only? Can we give only clomiphene, or can we give letrozole along with HMG 75? And then it realized that the pregnancy rate of letrozole with HMG was almost 55.7% cumulative pregnancy rate. So it was much better. So it opened up some era that not only letrozole is better, but its combination is better. So that's the next step for our clomiphene resistant patient. So then this randomized clinical trial came that yes, letrozole is associated with higher rate of ovulation, more dominant follicles, better endometrial thickness, those all advantages. Reproductive outcomes were much better. So then clomiphene went down, and letrozole we took up as a best ovulation induction drug. Now, can we use 5 milligram versus 2.5 milligram? What is the difference? Should we only stick to 2.5 or should we go to 5 milligram? So with 5 milligram, we had total number of follicles were significantly higher. So again, this study threw the light that pregnancy rate per cycle also was significantly better when instead of 2.5 we use 5 milligram. So again, there was a study who compared 5 milligram versus 7.5 milligram. It showed no, you don't need to use beyond 5 milligram. It doesn't change. So result of this study who compared did not show any advantage of using 7.5 milligram. So the conclusion came in that 5 milligram is enough. We don't want to go beyond 5 milligram. Now, this was a good study in 2016 which wanted to compare that efficiency of clomiphene citrate and letrozole when they combine with metformin. See, we know metformin with clomiphene has got advantage. It gives us better results. But does metformin combining with letrozole has any advantages? So what they realized that endometrial thickness more in favor of letrozole and metformin combination. If you look at the first cycle, when this combination was used, pregnancy rate was 17% versus clomiphene only 6.5. At the end of 3 cycles, 20 versus 9.6. So again, if you want to use letrozole, if you have a patient who's got a insulin resistant, use metformin along with letrozole. It will give you better pregnancy rate at the end of 3 cycles. So simple, if you have a PCO patient, investigate for insulin sensitizer, insulin resistance. If you feel, give insulin sensitizers for maybe a couple of months. Then start this stimulation protocols where you can give only letrozole from 5 milligram per day, second day to day 6, and follow the follicular monitoring. Typically, this will give only one dominant follicle. You won't get more 3 or 4 follicles or 2 follicles. If you want that 2 or 3 follicles, then you need to add HMG. So give letrozole for 5 days. From day 7, you can give low dose of HMG, that is 75 IU, but please give it daily. Please give it daily. Don't give it alternate day. The problem is, can you remain one day without any food? No, we can't. So same way, if follicular growth rate needs a pace. So they also need a daily pulsatile FSH. So you have to give it daily. Remember that. It will give us a better results because it will give you synchronized follicular growth when you have 2-3 follicles. Because if you don't give it one day, you will see fluctuations in the serum FSH levels and some follicles will go into atresia. So please give it daily. You can use low dose, enough, 75 is enough. If you feel that follicle is growing, you can step up to 150, no problem. But monitor follicles daily, monitor follicles by giving daily HMG. Now if you want that, the theory says that if a woman develops 4 oocytes, only 1 out of 4 will give rise to a good competent blastocyst. If you understand this theory, then we will always like to have, if one cycle gives me 3 or 4 oocytes ovulated and available for fertilization, my chances in one cycle going to increase. And for that matter, what you need to go to that physiological level. So you need to increase FSH beyond the threshold and let the levels remain above the threshold, above that, don't let it fall down. So what you can do, this protocol helps for that. You give letrozole only on 2nd and 3rd day, and 4th day onwards only introduce gonadotropins. There you can start giving either 75 or 150. So what it happens, it's a pure gonadotropins, biological hormone. It remains in the circulation, FSH remains above the threshold line. Your no follicle is going to go into atresia. So what you want to get is 2 or 3 follicles are growing in synchrony. Nothing is inferior or 5 millimeter lesser than the dominant follicle. You will have 2-3 follicles which are, so when they ovulate, they will give you more M2 oocytes. And if 3 or 4 M2 oocytes ovulate, then there are good chance that your chances of pregnancy in one cycle also increases. So this theory again goes back to the physiology. Now gonadotropins, we know different preparation. I don't need to tell you this. When to use? Remember, first choice is 2 cycles of letrozole. Now if you don't have pregnancy with single follicle ovulation, time is 3rd cycle is to go for multiple follicles, that is 2 or 3 dominant follicles. There gonadotropins role comes. But we need to keep it in mind that we don't want multiple pregnancy. So use judiciously, but in an adequate dose. When low dose HMG pure gonadotropins was compared with clomiphene in clomiphene resistant patient, it proven better in terms of every parameter: clinical pregnancy, live birth rate, multiple live birth rate, number of pre-ovulatory follicles and ET. Everything was in favor of HMG. So gonadotropins are better. Then why they are not first choice? Only reason is that it gives a little slightly higher multiple pregnancy rate, and that's what we don't want. That is not a good outcome of your treatment. So even recombinant FSH you can use. Still with comparison with clomiphene, it gives you much better reproductive outcomes. So gonadotropins are better. They give shorter duration of treatment, lower total gonadotropin zones, and better follicular and endometrial milieu or characteristics. So gonadotropins gives you better outcomes and better parameters, but you have to seriously use it very properly, because we don't want, because with gonadotropins you can have 5, 6, 7 follicles developing if the dose is not proper. I'll skip this few and go to the protocol. So you can directly start from second day. So if you want to use recombinant FSH, really you don't need to start 75 IU. Only dose, starting dose should be either 37.5 or only 50 IU, which is possible. This titration is possible with recombinant FSH. But with 75, if you want to give HMG, then you have to, starting dose should be 75. Then you monitor. Now, depending on the dominance of the follicle or follicular size, you can decide to step up the dose and increase it till you find a good growth of the follicle. Now, when you use gonadotropins, remember how you should judge that my dose is adequate. A follicle has to develop 1.5 to 2 millimeter per day. If it is growing good, there is no need to increase the doses. If it is only 0.5 to 1 millimeter, you need to step up. Okay, because that's what is the advantage of using gonadotropins. Now we did this study, which I wanted. My whole point of intention here today is, when you want to use oral ovulogins with gonadotropins with this protocol, which I mentioned that you introduce gonadotropins by 4th day. So we did our own retrospective analysis and we checked our implantation rate, clinical pregnancy rate and miscarriage rate per stimulation cycle. What we realized, we use clomiphene on 2nd, 3rd day, and 4th day onward we introduce HMG 150, and we did almost all PCO patients. We did this stimulation cycle. What we realized, the positive pregnancy test per cycle was found to be 26%. Per cycle 26%, which was quite good. Clinical pregnancy rate was 17.48%. So cardiac activity out of this 26% patient, 17% had a good cardiac activity at 7 weeks. Miscarriage rate was only 9%. Then we calculated our per patient. Like suppose I might do 3 cycles for one patient. So I wanted to know if 100 patients I subjected, how much is the pregnancy rate for my patient if I do these cycles in this protocol. Then we found out that positive pregnancy was 47% per patient. Per patient which was subjected with this protocol. Cumulative pregnancy rate was 31% and miscarriage rate 16%. Now, let's see the main outcome, because gonadotropins is multiple pregnancy, we are more worried. Then we realized out of these all 25 pregnant patients, only one patient had triplet. So it was 4%. 6 out of 25 patients had twin gestation, that was 24%. Now that was little slightly higher than expected. And that's what 18 out of 25 patients had a single gestation, almost 72% had a single gestation. So it was not bad. So remember, if you want to increase your pregnancy rate, because we know IUI treatment cycles, ovulation induction IUI treatment cycle gives us a very average pregnancy rate. We need to step up with certain protocols where we increase our chances of getting success in the same cycle. And these are important things. Now what can be the adjuvants, the last important point, what adjuvants we can use? Suppose you are still want to use, you are a kind of a very, no, I want to use clomiphene only because I am happy and I am more satisfied with that drug as an ovulation induction drug. If you want to increase your ovulation rate with clomiphene, few adjuvants if you add, then it will help you to increase your ovulation rate and pregnancy rate, and that is CoQ. what is CoQ is nothing but is a good antioxidant which is naturally present in every cell membrane of the body. So if you give CoQ from outside, it has been seen that CoQ with clomiphene, ovulation rate increased to 70%, pregnancy rate which was increased to 48% in comparison with, we continued only clomiphene without CoQ. When it was stratified by obesity, means only obese patients were compared. Again, obese patient had a ovulation rate which was on the lower side, and non-obese patient had a 85% ovulation rate. Pregnancy rate was also with non-obese patient. So if you use CoQ with especially average weight or lower than average weight, I think those clomiphene resistance patients will do well with CoQ. Again, it has been seen that in clomiphene resistance, if you use oral contraceptive pills one cycle prior to your ovulation induction, it's going to down regulate pituitary. It's going to keep that LH also on the lower side during early follicular phase. So OC pills proven again better option as an adjuvant for clomiphene induction cycles. As we have seen, metformin or N-acetylcysteine, again, if you give N-acetylcysteine along with clomiphene, it has shown a significantly increased ovulation and pregnancy rate. So these adjuvants are good. So if you want to do clomiphene-induced cycle, these are the few things which you can add as adjuvants, and they have shown a better results. Ovarian drilling, I think big no, it's a last resort, we know. Still there are a lot of endoscopies, they practice ovarian drilling, and I think I urge all of them, please stop doing it. Because we don't need a surgical way to ovulate her. We don't need it. We have fantastic ovulation induction drugs. We just need to learn our skill to use them properly. Take my word and practice it. You use letrozole with HMG, you will not have single cycle where there is no follicular growth. Experience comes from 17 years. But no ovarian drilling. Please stop doing it. It's not required. Ovarian drilling is reserved only for those patients who cannot follow up with you. We know that possibly a poor patient, far distance patient who cannot follow up, you feel that I do drilling and I leave her alone because spontaneous pregnancy rate is good with drilling, but at the end of 18-20 months, at the end of 1.5 years to 2 years. But it is not shortest way of achieving a pregnancy. It has shown quite a side effects, destruction of ovarian reserve, ovarian adhesions. They are all side effects of ovarian drilling. So benefits are lower than the risk, and that's what we need to understand. The evidence is also clear. If you compare ovarian drilling with the gonadotropins, the pregnancy rates, live birth rate are lesser. So that should be your last resort, and I told you where you can use ovarian drilling. I think I'll skip now to summarize. Ovulation induction in PCOS needs individualization. Letrozole should be our first choice. Letrozole with HMG gives better clinical pregnancy rate than only clomiphene alone or clomiphene with metformin. And metformin as an insulin sensitizer is a very useful drug. I always feel that the moment I diagnose PCOS patient, I always like to put the patient on metformin first. Now the previous old dictum says that you select only obese PCOS patient and put them on metformin. Average PCO patient do not need them because they are only 20%. That incidence is quite old. We see now lot of below average weight PCO patient has an insulin resistance, and that is what is reducing our success rate. So I always feel that metformin should be started for our all PCO patients, and then use a ovulation induction drug. Do not use ovarian drilling as your first strategy. And sometimes those who are doing gonadotropin cycles learn how to use GnRH antagonists, because the biggest cause of failure with gonadotropin cycle is a premature LH surge. That has to be diagnosed. Maybe some other day I will speak about it. So true scholarship consists in knowing what things exist. We just need to know the physiology, endocrinology, and that's it. We have to handle the drugs. But what they mean, it is not memory, but the judgment. Whose judgment? It is our judgment. It's not what literature says. It is our own experience. When you start using drugs, will make you much better expert in handling and giving you pregnancy in a shortest time. So thank you very much for the patient hearing.
Explanation of all ovulation induction drugs. So when do you say PCO resistant means following 3 cycles of clomiphene citrate? But for the first time the PCO patient comes, ovulation induction, what is the drug of choice you are telling? Letrozole. Should we start then metformin along with that?
I will recommend yes.
Yes.
Only thing is I always recommend is that also do a GTT, 75 gram 2 hour GTT, because 20% of your PCOS patient
Insulin.
not only have a insulin resistance but they do have a diabetes.
That we know.
So we will miss out them who needs even beyond metformin.
But people who do not have insulin resistance, normal blood sugars, and even in fasting insulin levels normal.
Yes.
Should be.
So what you can do in such patients is, because sometimes subclinical insulin resistance is not picked up by GTT test. Okay. So what you should do is you should follow the ovulation induction cycles. The moment you see luteinized unruptured follicle within the time frame of
Those levels,
ovulation,
till
that is
now,
typically
none
within
of the
48 hours
tests
from
practically
SCG.
which we do
If you have a
nowadays
luteinized unruptured
better than
follicle,
each other.
1 or 2 cycles,
you have to
it's
rely
better
on
to put them on
GTT because it
metformin,
is simple,
even irrespective of your
very
GTT
reproducible,
report. So
and
that is
it
very
gives
important.
you idea
And
because we
also
don't want to miss
important
out
is
patients
look
who are
for the
actually having
clinical signs.
diabetes.
So even
Their
acanthosis
insulin
nigricans,
resistance is severe,
hirsutism
where they
patient,
are having
I think
sugars
you
like diabetes
don't
and they
need
need not
biochemistry
only
test
metformin,
to
but more
make you
additional
understand
drugs to
that
control
she
their
does
disease.
have an insulin
And that's why
resistance.
please
You
do
can
GTT
Basically,
for
they are
start with
symptomatic
clinical
having
signs.
nigricans and all, but insulin levels so
metformin
normal
to
sometimes.
all your
Yeah, that's what,
PCOS
if
help
you
you
compare
definitely
GTT
You
with
don't
fasting
know
insulin and those levels,
Which is a kind of a
till now,
tip of the
none of the
iceberg which is
tests
lying below the
practically
sea,
which we do
which we don't
nowadays
see.
is superior than
You
each
cannot
other.
diagnose by every test.
So you have to
That's
rely
what
on
it is.
GTT. Why? Because it is simple, very easily reproducible, and it gives you idea, because we don't want to miss out patients who are actually having diabetes. Their insulin resistance is severe, where they are having sugars like diabetes and they need not only metformin but more additional drugs to control their sugars. And that's why please do GTT for every patient and give metformin to all of your PCO patients. It will help you definitely to reduce that insulin resistance, which is a kind of a tip of the iceberg which is lying below the sea, which we don't see, which we cannot diagnose by every test. That's why it is important.
Thank you once again. Thank you very much.
Thank you.